Donc, je suis Yann Gallagher, je co-dirige CerebrUM avec Frédéric Gosselin. Mais je vais vous présenter la personne qui va présenter notre conférencier. Plusieurs d'entre vous la connaissez, là, c'est Dr. Sylvie qui est professeur ici au département, qui est aussi, qui dirige aussi le réseau québécois sur le vieillissement et qui a une chaire de recherche en neurosciences cognitives et plasticité cérébrale du vieillissement. Donc, je lui laisse le plancher pour présenter notre conférence.
Bonjour. C'est vraiment un grand honneur et un plaisir pour moi de vous présenter le professeur Arseny Sokolov de l'Université de Lausanne. C'est quelqu'un que j'ai connu dans le cadre de la World Federation of Neurorehabilitation. Et là, j'ai découvert un scientifique extraordinaire. C'est aussi quelqu'un qui est neurologue, qui fait beaucoup de pratiques cliniques. C'est quelqu'un qui dirige aussi une grande unité. Il est depuis novembre 2024 le chef du service universitaire de neuroréhabilitation du Centre hospitalier universitaire vaudois et l'Institution de Lavigny. Donc, c'est quelqu'un qui travaille beaucoup. C'est un spécialiste évidemment en neurologie, en neuroréhabilitation. Vous allez entendre ses travaux. Il utilise une approche très multimodale, où il associe la neuroimagerie, les technologies, les interventions, des fonctions cognitives, mais aussi affectives, sociales. Donc, quelqu'un qui a un spectre très large, beaucoup d'outils pour lesquels il a une grande expertise. Alors, on est très content de l'accueillir aujourd'hui. Je lui souhaite la bienvenue en notre nom.
Introduction, merci pour l'invitation, aussi à Anne et Frédéric et à tous les cérébraux. Je vais faire une présentation en anglais par contre, parce que on va aussi s'assurer que tout le monde le comprenne aussi. Mais généralement, c'est plus simple aussi pour moi. Je commence un retour à Montréal depuis 15 ans. J'étais à McGill comme étudiant des études de l'école de médecine, donc c'est très joli de retrouver cette belle ville maintenant sous la neige. Moi j'étais en août, c'était un petit peu plus chaud, et c'est très intéressant. Voilà, je vais parler plus de la cognitive neurorehabilitation aujourd'hui. And as Sylvie pointed out, we have a multimodal approach, also including brain imaging and neuroimaging. Today, I will be mainly talking about evidence-based medicine and also about behavioral interventions, because this is already a big chunk to take. And we only have 1 hour for analysis, so the neuroimaging will be made for another time. I'll be happy to answer any questions on that. So if we talk about cognitive neurorehabilitation, then first of all, we should understand what is going on in neurorehabilitation and how do we perform neurorehabilitation. In general, we try to partition neurorehabilitation in 2 or 3 different strategies between restoration and reorganization on one side and compensation on the other, which means that when we restore or reorganize, we try to retrain a function that has been lost by the brain following brain damage like a stroke or traumatic brain injury. Whereas when we compensate this, we are trying to do psychoeducation, for example, in neuropsychology, we're trying to do any trainings in physical therapy, occupational therapy, so that somebody can learn to do things like writing with the left hand when he was beforehand a right-hander after a stroke and he's not able to use the right hand anymore, for example. So it's really to try to find a balance between the 2 of them, because both of them will help the patient to come back to everyday life. And you can imagine that once we are done with restoring, we will be needing more and more compensation so that the patient can really return in the best possible way to his life. The question 2 or 3 is whether reorganization and restoration can really be separated out. And I think there was a tendency over the past decade or 2 to try to think about the 3 of them, which was an advance of just saying we're training the brain regions that are still around and adjacent to the lesion to try to take over the function and to recover the function, to a more network approach, saying that when we are training, we are also stimulating different networks and we are trying to promote network organization. So in some ways, neuropsychological rehabilitation and cognitive neurorehabilitation took the same approach as neuroscience in general, going more into networks. But I think today it is safe to say that we are only talking about restoration and reorganization as one single term, because it's really hard to imagine that the brain will recover around the brain lesion without any remote network effect and without network dynamics. So I will be going for the 2 concepts in order to explain that to you in more detail. And when I'm talking about new horizons, then I'm going to be mainly talking about restoration, because we know pretty well, and Sylvie has contributed to that a lot in the neurocognitive disorder domain and the dementia domain and aging domain, that we have a lot of validated approaches in compensation and psychoeducation. We have way less validated approaches in restoration, actually. And restoration is really drilling. That means that we are giving people the maximum amount of exercises, repetitions. Again, there's another paradigm in neurorehabilitation that the brain is not like a muscle. that if you train several repetitions and frequencies, it's not going to change much. Well, actually, there is much data now that is showing that this is the case. So if you're doing a lot of repetitions, then your brain will recover. The problem from previous approaches is that we never had enough resources to actually provide the dosage that it needed. And so when we're talking about neurorehabilitation and research in particular, we should always try to keep in mind what is the ultimate goal of what we do with our patients, be it in the clinics or be it in the research. Well, the ultimate goal is to alleviate cognitive complaints, is to improve everyday cognitive function. And for example, this is a study, meta-analysis on people with multiple sclerosis, where fatigue is a big concern. And I'm not sure if you realize, but for stroke patients and TBI, fatigue is going to be a concern in about 80% of the patients. And fatigue is going to be definitely the ultimate factor that is actually preventing from going back to work at 100% or from taking care of the family in the way it should be. So if you look into studies that have been using computerized cognitive training, which is exercise delivered using digital tools, you do see that actually the improvement of cognitive complaints is there, but with a very modest effect size, which is of 0.19, and that actually here, when you aggregate the different studies, of which there are not much, you're not even crossing the zero line clearly with the confidence intervals. So actually we, for now, don't have really evidence that computerized cognitive training will alleviate cognitive complaints. And this is one of the big reproaches that is done to cognitive neurorehabilitation in particular, is that we are training specific functions. They don't transfer to other functions, and they don't transfer to everyday life. So in the end, you're developing an exercise, you're developing an approach, you're very proud of it. You give it to your patients. On the automatic, it works out really well, but in the end, it doesn't change much for your patients. And they have been training for 8, 12, sometimes 26 weeks on such an approach. And fatigue is slightly better. So at least the confidence interval is a bit smaller here, but you also see that the effect size is very modest with 0.3. And this is what the presentation is going to be about. How are we going to really to promote changes in everyday life for patients, be them with MS, be them with stroke, be them with TBI. And in the end, I'm going to talk a small shout out to Sylvie with respect to dementia. So one of the major things we work on is executive deficits, and that's also not just by accident. First of all, we like challenges. Executive deficits is something that is the most difficult to rehabilitate in people with TBI and stroke, and also MS. But also executive deficits is one of the big predictors of how people can go back to everyday life, occupation, and of quality of life. And so what we know from several studies is that when you're doing metacognitive strategy training, so again, we're going back to this compensational training and the psychoeducation, which also involves promoting self-monitoring, self-regulation, including explicit feedback to the patients, they tend to do better. There is this errorless skill-specific training, which may be useful for severe executive deficits. So you avoid failures for the patient when the patient is training. You avoid failures in the rehabilitation. And there is still a question mark because it's actually still a slightly debated issue whether that's really true, but this is certainly an approach to study. And one interesting observation done in Montreal, which you may be aware of, by the group of Cisneros and colleagues, was that if you do 24 sessions of general planning, problem solving, goal management, and self-awareness in people with traumatic brain injury, in the older range, 57 to 90, so we're pretty much outside the occupational range, they can do better than in standard neurorehabilitation alone. And which shows for me, most importantly, that actually those people here, the older people, have them, be them with TBI or be them with dementia, they actually still have a compensatory potential and they have plasticity in their brain, which can be quite significant. So we should not put any limits on that either. The big issue we have in neurorehabilitation, and that's not just a problem for cognitive neurorehabilitation, is the drop in therapy. And this is the case in most countries and most centers, in most regions. I'm not sure how it is here in Montreal, and happy to discuss that afterwards. But in Switzerland, when you're in a hospital, in a clinic, which is providing neurorehabilitation such as ours, you're actually having something like 18 to 20 units of 45, sometimes 30 minutes sessions of physical therapy, occupational therapy, neuropsychology, and speech therapy. And this goes on for 2-3 months. Then you go home. And the simple fact of going home, you drop to 1 to 2 to 3 therapies, sometimes 0 therapies during several weeks because you're not able to coordinate and to organize yourself with therapists. There is no real follow-up. There is no real continuum of care. The worst thing is that when you think about stroke and TBI patients, like in this diagram, they actually still exhibit a very important potential for recovery. And that means that we are not really promoting and fostering and exploiting this potential. And people are left alone. People have a sensation of being abandoned once they leave the hospital, and they are facing true problems in everything which they may not have been clearly aware of while they were still in the protected environment in the hospital. So the challenges in cognitive rehabilitation, the very first challenge is the dose, how to make the brain work out, how to make the brain work like a muscle and actually overcome the deficits that the person is living. Those are associated to resources. So yes, if we had unlimited resources in neuropsychologists and patient therapists, everything would be wonderful. But this is never going to be the case. There is a demographic change. There is more and more people needing. There is less and less specialists because those jobs like nurses, like neuropsychologists, like physical therapists, you know it yourself, are maybe not the most lucrative in terms of also even recognition, but also economically. So we have less and less experts, and we also don't have the reimbursement system. So for now, this is our experience. We are proposing now an outpatient rehabilitation center in Lausanne, which again, Switzerland is not a poor country, by far not. Well, actually, we would not be able to cover our expenses if we are putting up the system that would actually be needed by the patients. So it's not really easy for now. And there's also the question of accessibility. And I think in Canada, as far as I remember, that can be an issue when people live quite far away. They maybe come to Montreal for a stroke treatment when they are inpatients, and then they go home to some region or some territory that is a few hundred kilometers away. And then the question is, how do they benefit from specialized rehabilitation care? We have the same issue in Switzerland, where distances are much smaller, but still, once the patient is something like 45, 60 minutes away, is not able to drive for motor reasons or cognitive reasons, there is an issue for that person to come to the center to receive high quality rehabilitation. Well, then before we talk about implementation, which is here, those resources, accessibility, we should talk about evidence. And that is a big issue in our domain. Actually, the evidence in neurorehabilitation is not really convincing so far. There are some approaches which are really interesting, some approaches which are well validated, but they usually remain regional. They maybe remain national if we are lucky, but they're not really transferred into other countries. People don't pick that up. There is no culture. And I always make the link to stroke. Once people tried to make thrombolysis, they did international trials. It didn't work out right away, but then everybody picked that up, and now everybody follows pretty much the same protocol. Should get in the same place in neurorehabilitation. And for now, neurorehabilitation is a bit like you're going to a wellness treatment somewhere. Your doctor is a bit of something, a magician, and he's thinking, well, I'm going to do that for you and that for you because I read it somewhere, but there is really no clear evidence of saying this should be done that way for that patient with this stage, with this approach and specialization. So this is where we talk about standardization, that we really need something that needs to be taken over by international consensus, that needs to be driven by international trials and finally implemented also across countries. And then once we overcome those two barriers, we will talk into personalization, how to make proper precision neurorehabilitation arrive, and also about outcomes and transfer. And that's particularly true, as you've heard before, for cognitive neurorehabilitation, but that's also true for other types of rehabilitation, like physical occupational therapy, to really be sure that the patient are transferring what you're training with them with into everyday life. And so when we talk about transforming cognitive rehabilitation, what we propose is a continuum of care. And actually, this continuum of care starts already in the acute phase. That means in the first 2, 3, until 10, 15 days after stroke or TBI. You follow up in the inpatient rehabilitation, and then you have a proper outpatient rehabilitation, which is treating the patients. And then the patients are actually also able to benefit from that when they are at home. So it would also include some telerehabilitation. And the talk today will be mainly about outcomes and interventions. How do we measure success, and how do we put proper content into the interventions, and how do we harmonize it across different centers and across countries? How can we increase those efficiently, how can we personalize, where technology comes into play, but also other measures? And then a question about rigorous validation. I've heard a lot of comments over the last years that neurorehabilitation is not accessible to randomized controlled trials. It is not true. And I think we have some proofs here from Montreal that it's not true. This is certainly the way to go forward, but it needs to be done in a very smart way because we are talking about behavioral interventions. And you cannot just give a patient a pink pill or another pink pill, and they will not know which one is placebo and which is the pill, for example. But before talking about interventions and outcomes and validation, I would like to spend a short moment about screening and also monitoring of cognitive performance, for example. What is happening now, and I'm not sure you're aware, is if we are lucky, but if we are lucky in acute neurorehabilitation, in the first 3, 4, 5 days, people will get a neuropsychological testing. Then they go into inpatient neurorehabilitation, where at some point they get some more tests to complete the picture and to see how the evolution was. Then again, if they're lucky, not all centers also in Switzerland do that, they get something at discharge in terms of looking into how they evolved over the 2 or 3 months. And then this should be used then also as the entry into the outpatient unit. But then sometimes the gap between inpatient and outpatient can be 2, 3, up to 6 months. So you should be doing another neuropsychological test. And in the end of the outpatient neurorehabilitation, not always, but very often you would like also to monitor the effects and to see where you're going. The issue is in the inpatient NR, as I said, we are spending 2 to 3 months, and the outpatient can be 4 to 6 months, and that's not counting the gap that you may have. So the problem is actually that you do this neuropsychological tests. Imagine, you're doing this one, for example, and this one. And then in between, you're doing 4 to 6 months to 9 months of cognitive neurorehabilitation, state-of-the-art neurorehabilitation, but you actually don't know where the patient is standing, apart from observing the performances during your different trainings on the sessions. But you don't really have a formal view of where you are. And it is happening probably quite often that either you undertrain the patient, you don't train the patient sufficiently, or probably even worse, you overtrain the patient, giving them a lot of exercise. for a long time, depriving other patients from access to this kind of care, and then you actually already have attained your goals in terms of the objective measurements. So how to do that better? One possibility is through screening tests and also monitoring tests. We're working a lot about with adaptive video games. Here is one adaptive video game which is actually for evaluation, not for interventions. And the adaptivity should help you, in theory, to... Right? So technically, the adaptivity should be helping you to reach your threshold much quicker. If you're doing just predefined stages of different difficulty levels, then you will be taking a lot of time in a staircase procedure to get to what the patient's real performance is. But here, if you assume that the real performance is at 0 and you're always going pendulating around it, then you should be technically approximating this performance very quickly if your reaction time, for example, and reaction time limits are always adaptive and it's changing, or also the challenges that you're putting on the patient, giving him 4 or 6 elements to remember, for example. And then another feature of video games is that you get explicit feedback, which is certainly not the case in neuropsychological testing, right? Every neuropsychologist starting from his or her training in the first days will learn, don't give any feedback to the patient during the trials, don't give any feedback to the patients. So often I then see the patients in neurological clinic just after neuropsychological testing, and they're like, how did I do? I have no idea. They were so objective and so closed and so neutral. I have no idea. I was probably really bad. And that's often not the case. So the question is, can we get better in terms of approximating everyday life cognition with this thresholding and motivation? This is still an issue under investigation in my group. So I'm not going to show results on that right now, but we hope that's going to be the case, because today, I don't know if you know, but if you want to approximate subjective reports of cognitive function in everyday life, your best predictors are mood, anxiety, and depression, and not neuropsychological testing. And so this is the question, how can we change that? And how can we get into objective measures that are actually really showing what is going on with the patient? So we have this video game that was developed by colleagues in San Francisco, has already been used in that study that I'm citing below for multiple sclerosis. And here it's a module on cognitive flexibility, where you do see a symbol in the middle, and depending on the color or the shape of the symbol, as indicated below, you need to push the button which corresponds to one particular shape and one particular color, choosing between the left and the right. So you need to adapt to the different contexts. You need to adapt to the different indication instruction on the iPad. And when we compare that to the TAP flexibility, which is a computerized neuropsychological test of cognitive flexibility, we do see a very strong correlation in people who had a stroke and who are still in inpatient rehabilitation after 20 to 40 days after stroke, which shows that actually this kind of devices can be used very early on in the rehabilitation. And so what you can imagine is during those 2 or 3 months or 4 or 6 months of outpatient rehabilitation I showed you before, you could actually be doing your monitoring via iPads several times. And what you can do going through the rehabilitation process is really to monitor and adapt your rehabilitation according to the progress and the performances of the patient. Then this is a bit more interesting for dementia, but probably also going to be interesting for TBI and stroke. At some point, you have other tools which are not gamified, but also digital, again, coming from a group in San Francisco. TabCat is a tablet-based cognitive assessment tool, which actually has been shown to outperform the mocha in its sensitivity to pick up cognitive decline. And also when comparing that to PET data, it had a quite considerable AUC for just picking up amyloid beta in the brain. So that means that at 0.75, you'll be pretty good at picking up amyloid beta in the brain without performing a PET actually, just by a tablet test. 0.75 is still not very good for diagnostics, but 0.75 is quite promising to go forward. What is even more important is that there's a function topography. When you look into the different functions tested by the TabCat, such as favorite images, match, which is a processing speed test, and line orientation, which is a visuospatial test, you can actually go and predict tau loads in different regions, which would be specific for those kind of functions. And so once we have that, the monitoring, screening, and maybe some prediction of lesions, then we can turn into outcomes and interventions. What we have there is a flagship project financed by an agency in Switzerland, which is promoting collaborations between industry and academia. It's called Swiss Neurorehab. And it's a consortium that has 19 academic partners, including clinics for neurorehabilitation, and 14 medtech companies, such as mine, Mace, Coma, if you may have heard of them. It's financed half-half between the companies and this funding agency. So we received 11 million over 5 years, and with a goal of having evidence-based neurorehabilitation, a continuum of care, integrating neurotechnology, and I will talk about that in a minute, about how and also having neurorehabilitation registry, because then again, I told you about the pathways that are really sort of discontinuing and where you have gaps in the following of the patients in terms of the therapies. But in the same way, you also have gaps in following the data and the progression of the patients. So they are in one clinic, you have data there, then they go into a center and to therapists who are in the city. Then you have data there, and you actually have no idea what the clear trajectory of the patient is over time. And then the question is, how do we implement all of that? And we discussed it with Sylvie this morning. We will need a novel reimbursement system for this kind of technologies, for this kind of kidney rehabilitation, and also to provide the entire continuum of care to the patients. And this reimbursement system needs to take into account the socioeconomic impact of people who didn't receive proper rehabilitation and cannot go back to their usual life and their work. So I'm coming from Switzerland. I just flew in yesterday, and just a quick few facts about Switzerland and why it's interesting to do such a consensus study there. We only have 8.7 million inhabitants. I believe that's like 5 times the size of Montreal. It's not really huge. We occupy 0.28 per mil of global land surface. And we have 4 language and culture zones in there. So that's slightly more challenging than in Montreal. But I'm pretty, I can confirm to you that I was very impressed 2009 that in Montreal you just switch so easily between French and English. Not so much the case in the French and German parts for the other language. So much better here. But yeah, we have 4 different zones and 4 different approaches to neurorehabilitation and medicine in general, which need to be harmonized. They are harmonized on the federal level in some ways, but not completely. You all know that Switzerland is famous for chocolate. Chocolate, you may know, is a good factor, like especially dark chocolate is a good factor protecting against stroke. Nonetheless, we have 16,000 strokes a year in Switzerland. We have 5,000 moderate to severe TBIs that is also related to skiing. So right now, helicopters are flying all the time, which is not so much the case in the summer. And for that, we have 35 neurorehabilitation clinics in the country, and we have 5 university hospitals, most of which have neurorehabilitation services like the ours. And we have several medtech hubs in the Geneva Lake region, but also in other regions like Zurich, where we are collaborating with technology companies and technology people. So this is why we have this project, and this project is highly interdisciplinary. There is a socioeconomic part, there is a part of modeling the care and also looking into the reimbursements. There is a part data infrastructure. This is for the data registry. A part of therapeutic programs, obviously, for stroke, TBI, and spinal cord injury. And there is also a part for education and training to make the people and the professionals and also the patients more aware of those interdisciplinary challenges and how to move forward. This is where we are with the project. We're slightly delayed, but we just received ethical approval for the assessment of the current system. And so imagine again this picture of the continuum that I showed you. What we will do is to assess the patient from A to Z. And this is financed by research for now. This is also co-financed in kind by the companies and by the participating clinics. So over 18 months, we will recruit about 1,800 patients with stroke and TBI, and we will be able to talk about their trajectory up to 15 months after the injury, at least. And then afterwards, what is planned is that we have novel clinical programs, and those protocols are being developed right now. And so we can start assessment of a new model, which would be technology enhanced at different stages, be it inpatient or outpatient. The big goal of the project is being to overcome this gap that I showed you, this drop in therapies, going from 18 to 20 therapies to none or very little in the outpatient. So what we do from the clinical part, for which I'm responsible in the sub-project 2, is that we try to define clinical outcome measures and interventions. And here we are using 3-fold models. We are looking into the standard of care in Switzerland. So we are mapping how it is going on in different clinics in the different regions. We're looking at the best possible evidence and guidelines in the international papers and literature that is available and experts as well. And then we look into the technological opportunities which are provided by our partners in the consortium. And we do the same thing for interventions as well. So we always try to have an updating circle of looking what is going on right now, what would be the best recommendation, what can we implement from what we have in the consortium, maybe also outside, and what can be done. And then basically there is always a loop of optimization during this project to try to do that across the entire continuum. So you can imagine a wheel rolling across the entire consortium and trying to roll out the best possible technology enhanced procedures for the patients. But also one goal is, for example, that therapists, be them from the different professions, but also from different regions, start to speak the same language. Because what we also see is that in one clinic, people are doing procedure A, and it's the physical therapist who is doing, in another clinic, it's an occupational therapist who is doing that. And they do exactly the same thing, but they actually call it differently, and they have no idea that they do the same thing. So that's also something we try to overcome. One thing we managed already is having a consensus on neuropsychological follow-up, and those of you who know neuropsychology know how difficult that is, also especially given the different norms across the cultural regions. And we even managed that people align on norms that they can be using, but it's really difficult for people to accept that they are all using, for example, Australian or American norms in Switzerland, but there are no norms for the French-speaking people. And so they are saying, no, we cannot use the test, which is not quite true. but obviously there is some methodological considerations to have. And so what we have here is the current usage in the Swiss clinics from 0 to 5. So we just asked by a Likert scale how often they use the test. We also asked about the utility, which I'm not showing here. And then we had an eDelphi consensus between the experts from the 10 participating clinics, which were saying how often should we be using this test, or is this test something that should be retained in a core battery when we follow people from stroke and TBI. So we also have test-retest issues. We also have to talk about that. But in general, this is the battery of tests that is proposed for executive function, for neglect, and for attention. And you see that there is not much difference between the various utilizations versus what people recommend in going forward, but there are some tests that are not used very often, and it helped us also to define better why certain tests should not be used, why certain tests should be used. What we also do is patient-reported outcome measures, and here we have a PPI effort. This is patient involvement and patient and public involvement. So it's co-construction, which I know that CHUV is also doing in her team since today. So basically what we did here is we proposed to people with multiple sclerosis 4 different questionnaires measuring everyday cognitive function. There is the multiple sclerosis neuropsychological questionnaire, a working memory questionnaire from France, the PDQ, which is the perceived deficits questionnaire, and the cognitive failures questionnaire. And we asked them to rate those questionnaires in terms of validity for their everyday life concerns, relevance, clarity, and also the length. And you see how those different questionnaires were rated. And at the same time, what we did, we asked clinical experts to do the same thing. And you see that actually there is pretty much good overlap between what the patients and the clinical experts think, but this is a wonderful tool, for example, here to choose the best possible outcome measure in terms of prompts between consensus between patients and clinicians. And so here, for example, in that specific case, we went for the PDQ, the perceived deficit questionnaire 20, to include as a principal outcome measure in our next study. You can do the same thing on other questionnaires like fatigue. And so here we have 3 fatigue questionnaires. We showed them to the patients here. We are right now showing them to the clinical experts as well. Pretty much the same setup here, but it's also looking into engagement, into length, into clarity, and also the range. That means is the range of dimensions that is covered by the fatigue, be it psychological, be it mental, be it cognitive, be it physical or psychosocial. Is that enough, or should it be more? And what you see here is that all of them are rated pretty much in a similar way when you aggregate all those different dimensions together, but we have a slight preference for the FSMC. That's the fatigue severity scale that has both a motor and cognitive and psychosocial perspective. And we basically are adding that into our protocols now as well, following the patient's opinion. So once we have those discussions about outcomes and interventions, and we also have discussions about how to put together composite scores and objective scores, but I didn't put it in the presentation today for the sake of time. We can discuss that later, maybe at the upper room or at the discussion. You can go into how to increase those efficiently and how to propose personalized interventions more and more. And there are several solutions. One of them is, for example, groups. Another one is technology, but they also have their trade-offs. What is very interesting about what we know is that there is a dose-response relationship in cognitive rehabilitation. If you do 10 sessions of working memory training versus an active control for 20 sessions, you have greater responses for both, for the active control and for the cognitive rehabilitation. But you do see that the 20-session program produces better changes in terms of the working memory than the 10 sessions. So we do know, but this is also one of the very rare and few and sparse studies that show us that that's the case in neuropsychological training and rehabilitation. We do know that dose matters. The question is then how to get there, and also how much is enough. And there is a very impressive study from CHUV and colleagues, which I believe is still unique in the area of neurorehabilitation. And it is on older adults, so it may not be applicable and generalizable to all populations and all ages. But what is interesting is that the range that is proposed in that study is somewhere between 12 and 16 sessions. And what the group could show is that this increased dose, when you go beyond this 12 to 16 range, is better for women, it's better for younger participants, which benefit more and have a bigger potential to benefit more when they have more amounts of session and greater dosage, for people with low education, and also for people with low risk of dementia. So there is something about brain reserve, there's something about cognitive reserve, there's also something about the response to the trainings, and this is certainly a way forward in this type of oriented personalization. And looking how can we best predict which patients should receive which kind of treatments. So this is what's happening right now. That's again the same diagram. You're an inpatient, you have 730 minutes per week. You go into your outpatient context, you go back home, and actually you're dropping to about 100 minutes per week because you only have 2 or 3 therapies per week. And what is the recommendation? Well, there is only very few recommendations for stroke and TBI. One of them comes from Canada describing the landscape in 2008. which counted on average about 360 minutes per week that will be provided to outpatients in Canada. I think that's very advanced in neurorehabilitation. But actually, if we look at the studies, then they are somewhere skyrocketing high. So those would be 900 minutes, but most studies actually from the US, for example, propose a treatment of 1,800 minutes per week in a short bout of a few weeks to try to treat the patients. So there is the question, how do we get there? First thing is treatment groups. This is something that we are installing more and more in Lausanne right now. We are having neuropsychological groups to work on working memory, for example, executive deficits as well. So here often we have 6 patients. We have 20 sessions over 10 weeks. And then the patients are having both restorative and compensatory approaches. They are learning more about working memory. They're learning more about the disease that they have. They learn more about how it affects the brain and also things that they can do in everyday life. There's also role plays. There's different scenarios that are analyzed together. And what we can see there is that between pre in red and post in yellow, you actually have significant changes and significant improvement after this kind of treatment. And this is also a cost-efficient treatment because you have 1 or 2 therapists treating 6 patients, which increase your outreach and increase the accessibility of this thing. The other thing is technological solutions. So it can help us to increase the dose and intensity in a very efficient way. Ideally, we should have technological solutions which are not requiring specialized supervision all the time. It can be an enhancing tool for therapists, but we are also pretty certain, also given the evidence that I showed you on the compensation, that we will never replace the therapist. It's more a question of trying to provide enhancements for the therapy and better tools to be more efficient. It can also bring about telerehabilitation, so we can have the possibility to basically deliver those kind of approaches at home, again, in a very efficient way. The pandemic showed us how we can use Zoom for psychoeducation and for monitoring, and so that can also be something interesting. And then this can also help us to monitor and follow up, as I showed you with the tablet game, for example, where you can really see where the patient going to that. So in the end, we think that technology is an avenue forward into providing innovative multimodal content to the patients. And again, technology is not the only solution. Music can be another, but it's certainly a nice way forward to propose to the patients, and patients love it. I have people who are 92 years old who have a stroke, who just fell from the bike when they had a stroke, and then they actually go back to normal life using our video games. And this is where I'm hesitant. Do I propose that to them or not? And they take it up very happily. And some others don't. Sometimes I have people who are 38 years old and they tell me I never touch a video game and computer, and I never will. It's all right. We need to find something that is good for the entire individual. So what I will be talking now is adaptive cognitive neurorehabilitation. And we know that both with HIV on the left side and with multiple sclerosis on the right, adaptive rehabilitation promotes better improvements in patients than if they have only a constant training, and the training that is not really adaptive to what they do. So you see improvements in working memory on the left, and you see improvements in processing speed measured by the single digits modalities. Some concept is actually to use technology in this innovative concept where we can do real-time closed-loop adaptability, just like in engineering. So actually you have the patient who is training with a tablet or with a computer or with VR. And the system in the VR or in the tablet is actually measuring the performance of the patient, is adapting the difficulty according to how the patient is performing at the right moment. So it's not changing a level in the next day or in the next week. It's changing the level for the next trial. You're doing a trial, you're being not quite fulfilling the framework and the limits that has been given for your reaction time. It means that on the next trial, your reaction time window will be slightly bigger. And if you're doing much better, then your reaction time gets more and more constrained. And basically, you need to follow up and try to stay at 70 to 80% of your maximum performance. And that has been shown in training science to be the best way to go forward also for cognitive exercise. And there was this pivotal study that was published in Nature now 12 years ago, where the colleagues at UCSF measured the multitasking capacities in patients to see how they actually decline from different decades of life, from the 20s to the 70s. And you see that there is a decline when you're doing several tasks in your index of multitasking. So what they did then is recruiting patients, but not patients, but participants without signs of clinical dementia, but exactly with this decline of multitasking, which is considered normal with aging. And they divided them in 3 groups. One was training with a video game using 2 tasks. Another one was training with a video game only using 1 task. And the other one was a no-contact control group. The video game, inspired by the San Francisco and California hills, was driving this people, keeping it on track, keeping it in the speed limits that are shown by the yellow and red lights, but also reacting selectively to specific geometric symbols, which are green circles. And so you should be avoiding clicking the correct button if you see any other geometric symbol. So the group that had the single task, they were just driving the car. The group with the 2 tasks, they were actually doing both tasks, and the other one was not doing anything at all. And what they see is that there is significant benefit to multitasking. You see that people start from where they are 65, 70 years old. So this is from the range they were actually starting. Or no contact don't really change significantly. In green, people who do one task, they improve after 1 month of training, but go back to the initial level after 6 months without training. And the people in the blue group who were the 2 tasks training, they actually improved significantly and had also effects persisting at 6 months follow. After that, they took it from a simple computer game, really looking old school, into a tablet. They also provided and sold the license to a company that is based in Boston. And those people ran trials published in Lancet Digital Health in 2020 for those who are interested. And the tool received actually approval as a training for adolescents. It's an add-on training now that can be prescribed by doctors in America for ADHD. And so we are also inspired by that, working together with MindMaze, that is a company located in Lausanne, just metro right away from us, closer than Atwater from here. And this is a VR sports game where we are training working memory, and we integrate that into sports activities where you're actually fencing. We also have sports activities with soccer, football. There's also something that with mountain climbing that's being developed. And what you see here is that actually you had to remember the different balls that were displayed. I'll show that once again. Then you have a short phase of interference where you're not doing much. And then you have to select between always 2 balls that are appearing again, which one you are attacking and which one you're destroying. And if you're correct, then you can also attack the avatar who is fencing against you. If you're taking the wrong choice, then the avatar will attack you or be able to defend. And so this is something that the patients like a lot. And our concept right now is to actually integrate that with the group training that I showed you before. So the group training is 2 sessions per week over 10 weeks. What we do here is that on the same day or same morning when the patients are there for the group, we are actually also adding a session of VR. So they get in total 40 sessions over 10 weeks, 10 of more psychoeducation and some restoration with a neuropsychologist, and 10 where there are students which are supervising them as a group, and also promoting metacognition between the different trials and modules of the virtual reality. And what we can see here, this is for now a single case study. You see on the left in the very light blue bars, this is the pre-training performance. In darker blue, you see the post-training performance after those 10 weeks. And in gray, you see the follow-up, the retention after 6 months. And actually, we see that we are able to attain what we're looking for. We get the cognitive benefits. We get also benefits in tasks that are more ecological and showing transfer to everyday life. And most importantly, we get those benefits also to stay with the patients after 3 or 6 months, depending on when we measure them. So this is fulfilling the criteria that we're actually having into efficacious interventions. But this is now being tested, and I think by the end of 2025, we will have sufficient sample size to actually publish that. What are the outlooks for virtual reality? Well, I told you about the acute phase neurorehabilitation, which should be performed already in the first 2, 3 to 10 days. It is possible. Colleagues in Bern, in Switzerland, for example, put also virtual reality in intensive care, and they showed that it can be done. It needs a lot of logistics because it needs to be sterilized. It needs to be accepted by the patients. It needs to be accepted by the professionals. Bringing virtual reality into intensive care or even in our acute rehab units is not always easy. And the second thing is telerehabilitation, obviously, because if you have augmented or virtual reality, you can provide that to patients at home. There is an interesting study on upper limb rehabilitation that I'm citing here in 2020, which actually looked at the impact of multiplayer VR from home. So you're doing rehabilitation VR, proper scientific clinical rehabilitation, but people are connecting through their VR head-mounted device from home, and they are connected to avatars of other people, other patients at home, and they are doing this kind of training. And it shows a clear improvement in motivation adherence. It shows also some effects, better effects in terms of motor function, which is going to be confirmed, but this is certainly a way to go forward. And we're actually right now developing a project together with colleagues here from Montreal in order to develop this kind of telerehabilitation for people with TBI and stroke. Something I find very important in this context is also trying to overcome the barrier of cognition and physical. For now, we have lots of people working on sensory motor rehabilitation, other people working on cognitive and speech. And what we try to do is to integrate those. So what we have is a cognitive exercise game, which has also been developed by our colleagues in San Francisco. And this module, which is called Body Brain Trainer, has actually 3 different approaches. One of them is task switch, which is more cognitive flexibility. You see here my sports science master student who helped us to integrate the platform and to develop the platform in Lausanne, who is actually playing that game. And depending on whether you see the color or a vegetable in the middle, you need to choose the color or the vegetable that looks most like the one in the middle. So a morph between blue and red, and also a morph between roundish and a bit elongated. Then there is a second module of that game, which is actually looking into visual-spatial attention, which we're going to see in a second. It's called Visual Search. And so here what the patients do is that they see this green notch, which is showing the direction of where to go. This small tip shows you whether to go up or down. And there is also a yellow semicircle that appears that shows you in which visual field this green symbol will actually appear or not, because when you advance in your levels, then this yellow semicircle can also be misleading, and you need to pick that up and to follow in the direction. You see that the patients, I mean, here is my student, but he's training at a heart rate of 90. We usually try to push our patients to train with something like 120, 130. And this is also real-time adaptive gait. So people are actually doing their exercise both on the physical and cognitive side, which is adaptive. Here, this is a visual short-term memory task where you see the symbols that are lighting up, and then you have a short interference phase and also retention phase. And then you go and destroy with your feet and hands the different symbols. You do see that there is no joystick involved. Everything is measured by an optical camera, which is a Kinect. And the only thing that the patient is wearing is a chest belt, so we can get hold of the heart rate of the patient and actually adapt the game. And there are two loops that are interacting. So there's one loop for the distance to cover, which then promotes heart rate increases. And there is also another loop for the difference of the difficulty of the task. So for example, in the first task, your changes between blue and red will be a bit more obvious, and then they get more and more subtle as much as you progress on the game. So why do we do this cognitive exergaming? Well, first of all, physical effort alone can promote cognitive benefits in patients with MS. Also, cognitive motor dual tasking improves dynamic stability in MS patients. That means they have less falls. And that's also very important for frail older adults, for example, but also for stroke patients. And we do see that combined physical and cognitive exercise has synergistic effects on the brain. So actually, if you do both of them together and not in a parallel or dispatched fashion, then you can have greater benefits in terms of your cognitive function. So turning to the last part of my talk about the rigorous validation, we are having now several RCTs that are running with this body-brain training for people with MS, but also for people with stroke and neuro-HIV, people who have brain affection and sort of central nervous system affection due to chronic HIV. And here is a pilot RCT that we just finished on 24 patients with relapsing malignant MS between San Francisco and the CHUV. People were trained 3 times a week, 1 hour, over 4 weeks, compared to an active control, which was Duolingo, learning a language, a foreign language, together with stretching. So we tried to mimic the effort, and we actually were probably a bit ambitious in choosing that active control, because learning a language, as Sylvie can certainly say after the ENGAGE trial, is very promoting in terms of cognitive benefits. Our primary neuropsychological outcome is the SDMT. This is this measure of processing speeds. And then we also look into other neuropsychological, physical, and patient-reported outcomes. And we also have a 6-month follow-up, which is not yet completed. So I'm not going to show that now, but I'll be happy to report that soon. So before I show you the results, I wanted to spend a short slide talking about state-of-the-art RCT methodology. If you want to do randomized controlled trials in behavioral interventions, and that's also true not only for neurorehabilitation, but also psychiatric psychotherapy, for example, or other behavioral interventions, then there are several things to consider. In cognition in particular, you wouldn't be needing to watch out the learning effects, because when you present a patient with several neuropsychological tests, with the same neuropsychological tests several times one after the other, you will have per se improvements, unless it's somebody who is really rapidly declining or who has learning issues. And so if you don't take that into account, you're probably overestimating the effects of your treatment. And what we try to do is usually to have 1 or 2 or sometimes 3 testings with the same tests, and then we reach a plateau in terms of the performance, and then we are doing the intervention, and then we're actually measuring the outcome at the post-treatment. The other thing, and that I cannot insist enough, is to think about active control conditions. Again, we were probably a bit overly ambitious, and you will see that in the effects. But if you use passive control conditions, such as a waiting list, or even watching the commentaries where there is no active engagement and interaction, you're overestimating your treatment effects by about 33%. And I mean, this is published data, this is available, and we still continue doing that in the field of cognitive rehabilitation. So that's a bit of a pity, unless you cannot do it otherwise. The other thing is the identical context across arms. What usually happens in technology studies, that you have your fancy approach. This is your intervention arm. You make everything for that. The students come in, the patients come in. You have all the logistics. Everybody's happy in the clinic or in the research institute. It's a beautiful context. People get water, coffee, get the mental support, social support from the students. And the control group is actually just getting an iPad in their hands with an instruction of how it works. And they go home and they do it on their own. And we don't even know if they do it properly. We don't even know if the therapy dose is really respected, if it's not done properly. And so then you're already introducing a bias beyond the placebo effect. And what is done more and more, and actually quite often now in neurorehab and behavioral studies, is to do blinded assessments. So it's not the same neuropsychologist who's providing the training who will be assessing the patient. So obviously we try to avoid the bias from an interest in the success. So, well, I'm turning back to the data I was showing you in the very first slide. Maybe you remember the effect size of cognitive complaints in everyday life, previously 0.19. What we have here in the study, when we did the VDC study on Rett patients, that they have an improvement after 1 month of training, so 4 weeks of training, 12 sessions of 0.48. More than double the effect size that was shown previously in computerized cognitive training, because we added the game, because we added the real-time adaptation, and because we added the physical exercise. You do see that there is also a decline, which is quite important in people learning the language and doing stretching. Interesting enough, we selected stretching as a placebo control before all the studies coming out in the 20s that showed that actually stretching is a very strong promoter of cognitive health and cognitive improvement. And we see a similar effect, maybe even stronger in fatigue, where people also improve in terms of complaints on the scale by 0.53 in terms of effect size. That's also pretty much double what has been previously reported in the literature. And you see that here, the active control of Duolingo and stretching is not quite doing in the same way. But most importantly is that we have significant difference between the VBT arm and the MBT, which is the active control in mental quality of life, including cognitive function. And we also have a tendency for better quality of life and on the physical part for the cognitive exergame, but which is not significant. And we probably need much higher effect size, sample size to look into that. So following the pilot study, the Swiss National Science Foundation provided us with funding for a clinical trial in 4 centers. This is where we go into different cultural zones of Switzerland, but also a center in Italy, in Geneva. So we'll have 4 specialized MS rehabilitation centers running this study comparing VBT, the cognitive exergame, to RehaCom, which is a pretty much proxy to gold standard in terms of cognitive rehabilitation in MS. And we want to show superiority that actually with a combined real-time adaptive cognitive physical training, we can do better than the computerized cognitive training right now. It's going to be a 2-arm RCT. We just changed and drew back our ambitions because we really want to try and show the superiority. But it's going to be 192 patients that we recruit over 5 years, and the recruitment is going to start in the summer in Switzerland. So what we're going to do is those 192 patients will go into the VBT group and the RehaCom group, and we will have 3 times 60-minute sessions per week over 4 weeks with a 6 months follow-up, pretty much the same thing that we did in the pilot RCT. In our service, in our department of neurorehabilitation in the CHUV, we try to live and promote this kind of continuum as well in terms of promoting the care for the patient, the management from the patient, from the acute care and neurorehabilitation into inpatient neurorehabilitation, outpatient neurorehabilitation. Now it's all from one hand. Beforehand, there was no outpatient rehabilitation, and the acute rehabilitation was in the acute departments, which was also good, but obviously not the same as when neurorehabilitation is really looking and overseeing all the processes. We have the Neurorehab Research Center, which is a research group that is following and introducing different studies, RCTs, in the different stages of the rehabilitation. And with that, we try to promote state-of-the-art care. We try to promote cutting-edge research and interdisciplinary training, and in the end, go into clinical innovation. All of that together, having translational science and implementation science going in and trying to improve our patients' life. And in the end, I wanted to share a few words on cognitive dementia rehabilitation. There again, there are only small to moderate effects that have been reported so far in global cognition. Compensatory strategies work obviously for memory and attentional control. And for us, it's the same in stroke and TBI. We mainly compensatory strategies for now for long-term memory. And we believe that here as well, serious video games and virtual reality can be very promising, but there again, there is a huge heterogeneity in terms of the methodology used, in terms of the approaches used, and there is really not the consensus and very little international efforts on going forward on that. And why is that important? I mean, here you see a usual trajectory of the patients when they are having normal aging in the 2 green lines. They can go different ways, right? Because of different factors, it still doesn't mean that somebody has dementia. And one should also not think that dementia is just a usual feature of aging. Aging should be without dementia, even if you live until 101 or 102. But obviously, we are picking up more patients with dementia because we are living longer. And so people who are prone to dementia will also develop dementia. And it's not just a question of living longer to promote dementia, but it's actually that we just discover dementia more often because we have a longer time window with the patients. So in light blue, you see how people go down in terms of the preclinical context. So that means that they still don't have a dementia diagnosis, but they are dropping their cognitive function more than other people. And then they go into MCI, which is now called minor neurocognitive disorder in the darker blue. And then they go into the dementia, which is major neurocognitive disorder, which is in red. So where's the place of neurorehabilitation? Well, for now, what we mainly do is trying to support the patient, to try to give psychoeducation to the patient to the next of kin. And this is standard of care across most memory centers. Not here in Montreal, thanks to UCLD, but otherwise, pretty much everywhere, people diagnose the patients and then they tell them, well, you have dementia, your prognosis is this and that. We actually don't know. We're also not completely sure that we gave you the correct diagnosis in terms of dementia type. And well, now you should go home and wait, and we'll see you again in 1 year. And maybe you can take some drugs, which have quite a lot of secondary effects and unwished effects, and then we'll see. And then there's usually the psychiatrist taking over or the nursing home. So that's not really easy, and it's not really satisfying from the neurological perspective. Well, now if we do neurorehabilitation, what we try and what we can try to do is to decelerate the cognitive decline. And that means that hopefully people can be longer autonomous. Maybe it will also lengthen the time until fatal issue, until going into nursing home and need to be hospitalized. But in the future, and this is what we hope, is that we will get drugs that will actually promote that the disease is stabilizing. So it will really be not just symptomatic, what we have now, but really causal. And then you can imagine that rehabilitation can try to put people back on a trajectory that should be similar to low-level, lower-range cognitive aging, which is related to healthy aging. And then ideally, I was showing you the screening in the beginning of the talk, we should actually pick up people in this preclinical phase and be able to bring them back on the rails. So that should be the concept, but it also means that we should consider that the brain has the potential to recover and to improve itself, even if it's more limited, even if you're older and even if you have neurocognitive delay. And so to finish my talk, I think it is important not just for dementia, but also for other domains and all the other patient groups that I mentioned here today to think about multimodal cognitive rehabilitation. And I learned just today that the ENGAGE RCT is not ongoing anymore, but was finished. I don't know if you managed to have the 144 adults, maybe it's a bit more or less, but we can talk about that later. So people with memory complaints, 24 sessions of 2 hours over 4 months, and those people were either learning a music or a language. They also had attention video games, they had mnemonic and attention strategies, so compensatory approaches that would work. They had psychoeducation and low-intensity casual video games and documentary viewing as an active control. So this was the third arm of the study. And the primary endpoint was a competence score of episodic memory. We can talk about competence scores later, but it's really something really high level, and I think it's going to bore most of you. But it is very important to think, how do we represent cognition? And there's also correlates of brain structure and function to try and unveil the mechanisms that are changing with a 24-month follow-up. Really very important, because looking then, how do people do once we're done with the training? Is that really an impact? Is it really something worth pursuing? Because you will imagine insurances are not going to take something over where you only have a beautiful effect after 2 months and not after 6 months. They want something that is lasting in time, or something that can be reasonably repeated, but at good price. So what is important in our view is having a national consensus and cooperation, and then also having an international consensus cooperation, not just in Europe, but also beyond. And we have that kind of networks in Switzerland, also with different societies. Sylvie mentioned the local rehabilitation. And there are other big entities that are involved. The World Health Organization is getting more and more aware about rehabilitation. They have a rehabilitation 2030 plan. And there was also Lancet Neurology that launched a commission recently about rehabilitation and neurorehabilitation, thinking about how to move forward with an expert group around the world. So future horizons in cognitive rehabilitation, that's what I promised you with the title of the talk, is to think about multimodal, but also standardized treatments that can be widely accepted and widely distributed across different countries around the world. Thinking about neurotechnology, which means how can we personalize and also have an efficient increase in the dose? How can we validate those kind of approaches in state-of-the-art RCT studies? And this is really the way to go forward. And we should have multinational studies so that those approaches also get implemented very quickly. And those approaches ideally should have a transfer and impact on everyday life, because otherwise we are just changing neuropsychological proxies, and we are just changing, like somebody said, voodoo in fMRI. We're actually doing the same thing in rehabilitation sometimes, wanting to change an outcome measure, which is not really relevant in the end for patients. Mm-hmm. And then ideally, we should monitor the treatment effects. And something I did mention today, this is where it comes back to the neuroimaging, is to think also how can you stratify patients before. And I know that CHUV is doing this kind of work with her group, and other groups around the world also look into how can we use neurophysiology, how can we use imaging, how can we use small bouts of behavioral training in order to predict the treatment effects. And this is also going to be important before we enroll patients in something like 4 or 8 or 12 weeks of rehabilitation, is to know what is their real potential. Today, we can only approximate, and that's also part of the clinical intuition. But we really should get better to that. And that's why we would need evidence-based precision rehabilitation, cognitive rehabilitation, and I hope that this will be soon the case. So I would like to thank a lot to different entities that were kind enough to believe in our research and to sponsor that, and especially also to the different collaborators around the world, and especially in Lausanne for all their excellent work. Thanks a lot for your attention.
Il y a des questions? Oui, arrive.
Thank you. It's a lovely talk. I have some questions related to the closed group data content, where presumably there's, what I understand, some of these games that you're using, they will take one, sometimes two tasks, finally to increase. And I'm wondering how many of these tasks are actually tailored to a control parameter in the brain that we know we want to modify. In other words, in ADHD, there we have some hypotheses about, for example, theta to alpha ratio that we want specifically to the targets. Then you design again that will specifically go target those. Sometimes that proves useful, sometimes it doesn't do better than just a game off the shelf. So this is my question, is like control parameters, how important has this been for you in your experience so far, compared to actually good quality games that actually are more engaging, not necessarily targeting something, but actually ends up doing a good job?
Yeah, it's an excellent question. I think it's really at the core of this entire research line and line of trying to move care for patients forward. You mentioned the fact that some studies actually spend a lot of time in developing high-level neuropsychological, neuroscientifically inspired games, and when they tested them comparing to, I think I forgot the name of the game that was tested, but it was one of those shooter games. It was actually doing worse in terms of improving attention, and so it was not really worth of doing that. I think the big question for us is what kind of games can be used at which stage by patients. So when we talk about adult patients and younger patients, they can certainly use any kind of games, and it has been now reasonably shown that, for example, adolescents who are playing shooting games and different video games that are off the shelf will be better in terms of their general and fluid intelligence, but also in terms of their attentional capacity for peers who are not doing that later. So that can be useful, but it's very certain that we cannot bring those kind of things to the acute care, for example, or to patients who are inpatient hospitalized who are not yet able to do that kind of different things. And so what we try to do is when we're developing games, we are decomposing them into the cognitive components. So we are taking it more from the behavioral perspective, thinking and taking also knowledge from neuropsychological rehabilitation, which has been successful so far, trying to build it up in terms of the difficulty and in terms of the different modules. You're tackling one function first, then you're tackling two functions, then you're tackling three functions. And for example, when you think about a typical stroke patient, you will first rather work on the usual useful attention, on general attention, and then you will work more on the working memory and executive function. But so we try to avoid to get too inspired by the neurobiological mechanisms, although one has to say, and this is really good, that the neuropsychological models, the models of cognitive function are more and more correlated and inspired by what we know from the neurobiology and especially from network neuroscience. So we're getting there, but it's also true that we have seen in other groups certain failures where people try to just address the mechanisms that they were hoping for in the brain and try to have everyday life. Actually, once they did that, they showed that the game doesn't change anything in terms of the brain. It changed something in terms of the behavior that they look for, the objective cognitive test, and there is no impact on everyday life whatsoever. So we believe that the best avenue is really to think from the behavioral perspective, trying to take a neuropsychological model, enrich it, and then try to be multimodal. That means multi-domain, going on different cognitive domains at the same time as much as we can. Couple that with physical exercise, best case also lifestyle changes, and then you can promote the everyday life change. So it means instead of having something fine-tuned, which is stereotactic according to the neuroimaging, it would rather be the big hammer saying, okay, we now go with something multimodal and multidisciplinary to try to make the brain overcome a certain barrier in order to restore itself.
Merci, c'était vraiment super intéressant, flamboyant, je trouve quand même très excitée. Fait que, ben, j'ai dit qu'il y a beaucoup de questions. Une question que j'ai, c'est par rapport au transfert. Et il y a tout cette espèce de nuance là, que peut-être tu connais sur l'approche écologique, engagement, tout ça qui dit, bon, c'est bien beau, des tests, des entraînements très précis, etc. Mais dans le fond, la vraie vie est beaucoup plus riche que ça et que au bout du compte, c'est probablement beaucoup plus efficace en termes de transfert de mettre les gens dans des situations très riches. Ben, ça ressemble un petit peu à nos activités de loisirs où les gens, justement, vont être stimulés à différents niveaux. J'aimerais bien t'entendre d'abord, c'est que j'aurais peut-être aimé savoir un petit peu comment toi tu mesures le transfert dans la vraie vie. Mis à part là, tu as parlé des questionnaires sur la plaque, mais est-ce que tu essaies un peu d'aller voir ton BBT, là, ça c'est fabuleux, là. Mais est-ce que vous allez essayer d'aller voir dans la vraie vie? Et puis, qu'est-ce que tu penses de cette approche plus liées à l'engagement dans ce qui
Non, excellente question, Sylvie. C'est vrai que ce qu'on essaie de voir, alors avec les prompts, ce que je vous ai montré, c'est pour l'instant la meilleure façon qu'on a pour s'approximer de la participation du patient, donc de sa vraie capacité d'interagir avec d'autres, de travailler, d'être en harmonie et d'être aussi utile pour son entourage, à la maison, pour le ménage. Et ça, pour l'instant, malheureusement, c'est la meilleure des choses qu'on a, parce qu'on sait tous que les prompts, il y a aussi beaucoup de déviations. On sait que les prompts sont très influencés de nouveau par le mood, par l'anxiété et la dépression. Et donc, on essaie d'aller là-dedans aussi de réfléchir qu'est-ce qu'on peut faire. Est-ce qu'il y a par exemple des wearable devices, des choses aussi comme les appartements connectés, comme vous l'avez ici, que tu m'as montré. C'est de réfléchir est-ce qu'on peut mesurer un peu mieux le vrai impact sur la vie quotidienne. Sauf que là aussi, si on ne fait pas plusieurs tâches et plusieurs domaines, on va probablement être limité. On a des patients qui sont peut-être justement pas très bien, pas très améliorés dans la cuisine, mais qui vont être super bien sur leur lieu de travail. Après, ce qu'on utilise souvent, c'est les appréciations, mais ils sont aussi un peu subjectifs des ergothérapeutes qui accompagnent ces patients, qui nous racontent après comment ça se passe, et là, on le voit. Et au niveau du futur, il est clair qu'on va devoir avoir un peu plus de ces mesures de participation. Mais aujourd'hui, à mon sens, et c'est ma conviction aussi dans le projet qu'on est en train de développer, on le discute beaucoup avec différents experts dans le domaine, on se focalise beaucoup sur le côté objectif, et notamment en neuropsychologie, mais aussi en réhabilitation globalement. Et on ne pense pas forcément à l'impact de ces études sur la vraie vie, mais sur la vraie vie socio-économique du système de santé. Et le système de santé, il ne va pas très s'intéresser au fait est-ce qu'on a changé le BVMT ou le SDMT, il va s'intéresser est-ce qu'on a changé la participation du patient en termes de son work percentage, de son retour à la profession aussi en termes de mois. Est-ce que ça va durer 6 mois, est-ce que ça va durer 12 mois ou 24 mois pour retourner au travail de manière complète ou maximale? Et tout ça, aujourd'hui, ce n'est pas très bien représenté. Moi, je dirais qu'en réhabilitation, idéalement, quand on parle des patients qui sont en âge de travailler, on devrait avoir des mesures et on y arrive gentiment. Par exemple, justement, d'avoir une composite, comme on fait le RCS, entre le temps de réaction et l'efficacité, les réponses correctes. De même chose aussi, voir jusqu'à quel taux est-ce qu'il arrive et dans quel temps de travail, par exemple. Ça, pour moi, c'est une mesure vraiment robuste, mais elle est aussi très globale. Et puis, elle peut aussi être influencée par d'autres comorbidités, par des complications, par des récidives. Ce n'est pas toujours facile de dire. Nous, ce qu'on essaie aussi pour le transfert, et ça, je ne vous ai pas montré aujourd'hui au niveau du temps, mais on a justement toutes les mesures aussi objectives, cognitives et physiques. Et on essaie derrière de faire des analyses de médiation. Qu'est-ce qui a fait que quelqu'un a amélioré sa qualité de vie de manière tellement importante? Pour tout vous dire, le SDMT ici, qui est le primary outcome, il n'est pas différent entre les deux. Et même, on voit des petites tendances que apprendre une langue, et ça, moi, j'avais prédit comme postdoc il y a 6 ans en arrière qu'on a prévu le RCT, mais personne ne m'a écouté à l'époque. C'est que bien sûr que le Duolingo, il va avoir une amélioration du SDMT plus importante que notre jeu, parce que le SDMT, c'est associer des symboles à des chiffres. Et dans la langue, ce que vous faites, bah là, c'est français versus, je crois, espagnol, vous associez des mots français à des mots espagnols. Le transfert, il est très proche. Et c'est clair que le SDMT est plus amélioré. Mais derrière, justement, tout ce qui est fatigue, tout ce qui est plainte cognitive et tout ce qui est le vécu des patients en termes de qualité de vie. Et pour revenir à la question sur l'engagement, alors je pense que c'est important d'essayer de simuler et de stimuler les tâches qui sont vraiment de relevance pour les patients. Cela dit, j'ai la crainte, alors je pense que la cuisine, oui, on peut la faire et on peut la faire raisonnablement bien. Il y a beaucoup de groupes qui font ça. Il y a des groupes qui commencent maintenant en réalité virtuelle de faire des déplacements dans les villes pour tester et entraîner la mémoire épisodique. Mais derrière, par exemple, si on va sur des tâches qui sont importantes dans le travail, par exemple, ça va être très compliqué de les décliner. L'attention divisée, on arrive à peu près, mais là aussi dans un contexte normal, si ce n'est pas peut-être la conduite, qu'on a aussi discuté ce matin, ça va être compliqué. Pour nous, l'approche d'aller via les jeux, c'est que nous, on essaie que ça soit le maximum engagé pour les patients et on y arrive. Nos patients, dès qu'ils ratent une séance ou dès qu'ils ratent une semaine parce qu'ils ont été malades, ils veulent revenir à tout prix. On a un drop-out rate de 8%. Et donc, c'est vrai que c'est très impressionnant que les patients, ils forcent eux-mêmes pour essayer de venir, mais on voit aussi que c'est différent selon les pathologies. Les patients avec CEP, qui est une condition chronique, et on a toute cette peur de comment est-ce qu'on va être à 60, 70 ans si on a eu la maladie à 20, 25, elle fait que les patients, ils sont très, très preneurs de tout. Ils sont très, très motivés, ils viennent. Et j'ai la même étude chez les patients AVC, elle est un peu plus longue. On s'est dit qu'ils vont peut-être avoir besoin d'un peu plus de dosage au départ, mais c'était un peu au pif. Bah là, il y a 40% des patients qui refusent de venir. Et il y a la nasonusie. Et il y a aussi le fait qu'avec l'AVC, on pense que ça va, si on n'est pas à l'hôpital déjà, on pense que ça va bien récupérer. Et on n'a pas besoin. Mais pour nous, utiliser les jeux et la réalité virtuelle, il y a aussi un autre aspect qui pour moi sont très importants au niveau psychologique. Si les patients sont hospitalisés chez moi pendant 2-3 mois, c'est quand même un environnement un peu sombre, malgré tout ce qu'on fait, malgré les thérapeutes qui sont toujours là, malgré tous les exercices. Ce qui est dommage, c'est que justement, ils sont toujours confrontés avec leurs déficits, ils sont toujours confrontés avec la maladie, avec la difficulté, avec tout ce que ça fait. Et quand ils sont dans ces jeux, en fait, ils sont dans l'espace. Ils sont en train de jouer au cowboy, ils sont en train de jouer au fencing, donc à l'escalade, en français. Et puis là, tout d'un coup, ils sortent de ce contexte. Tout d'un coup, ils se sentent mieux. Et nous, on a eu des patients qui ont fait des reportages derrière, après avoir fait des jeux. Ils ont fait ça à la télé. Et un des patients, il a parlé tout ce que nous, on n'a jamais vraiment mis sur papier. C'est qu'il a dit, maman, au final, je me sentais que, au final, je ne suis pas stigmatisé par rapport à mon déficit. Je me sentais vraiment empowered. Je me sentais bien que je peux faire des choses. Ce n'était pas juste toujours dire, ah, monsieur, vous avez ça, ça ne marche pas, ça ne marche pas. Mais ça allait justement dans le sens de cette errorless learning aussi. Ils étaient avec ce côté adaptatif. Ils avaient l'impression qu'ils peuvent faire mieux. Et puis là, cette slide, je ne vous ai pas montré non plus aujourd'hui, mais il y a maintenant de plus en plus d'études qui montrent qu'on devrait donner aux patients l'impression qu'ils sont capables à faire un peu plus que ce qu'ils sont capables en réalité pour arriver à des meilleurs résultats derrière. Il ne faut pas non plus mentir, il ne faut pas non plus leur donner l'illusion qu'ils sont Superman tout de suite, comme je l'ai montré, mais c'est de leur donner un petit peu l'impression, juste un petit peu poussé. Et puis c'est avec ça qu'on arrive à souvent les stimuler pour qu'ils reviennent normalement dans leur vie.
Ben, peut-être juste dans notre programme mémo, on fait très attention à ça, de toujours s'assurer que les participants ont l'impression d'être compétents. Donc, pour que l'auto-efficacité, travailler l'auto-efficacité, leur donne l'impression qu'ils ont le pouvoir sur leur cognition aussi. Donc,
Non, ben s'il n'y a pas d'autres questions, je propose qu'on continue les questions de façon plus informelle avec un verre à la main. Donc, merci encore énormément.